Good afternoon, everyone. I want to start by thanking the course directors, especially Dr. Dan Chung, for inviting me each year to speak with you on chronic pancreatitis. Now, today's update includes all the relevant studies that have been published up until April of 2024. Now, the objectives of my talk are to not only provide a broad overview on chronic pancreatitis, but to specifically focus on the causes and risk factors of chronic pancreatitis, or CP, to understand its pathogenesis and diagnosis, and then finally to learn its clinical features and management. So let's start with the definition of chronic pancreatitis. The definition has been modified by a group of experts in the last 10 years, and it is now referred to as a syndrome, which is characterized by progressive and irreversible chronic inflammation and fibrosis of the pancreas, which results in damage to acinar, islet, and ductal cells. And as you know, it is usually associated with significant abdominal pain, malabsorption, diabetes, risk of pancreatic cancer, and other complications. Now, this was the traditional definition that was modified in 2016 to not only include features of end-stage disease, but also to add disease mechanism. Hence, this syndrome occurs in individuals who have underlying genetic, metabolic, and environmental or other risk factors, who then develop a persistent pathologic response to parenchymal injury or stress. Now, there are several classifications of chronic pancreatitis, but the most popular one is Tiger O classification, as it directly addresses the mechanism of disease and risk factors. And as shown in this slide, various risk factors are comprehensively grouped, such as toxic metabolic, idiopathic, genetic, autoimmune, recurrent and severe acute pancreatitis that is associated with chronic pancreatitis, and obstructive risk factors. Now, the risk of developing chronic pancreatitis depends on one or more of these factors and how they interact with each other. Now, the current thinking about the pathogenesis of chronic pancreatitis is that progression from acute pancreatitis to recurrent acute pancreatitis and eventually to end-stage chronic pancreatitis is a sequential process. Hence, the development of chronic pancreatitis can be easily explained by the two-hit hypothesis model. And in this model, in the setting of appropriate risk factors, either genetic, metabolic, or environmental, the first episode of acute pancreatitis, also referred to as the first hit, activates the immune system in the individual, either followed by complete recovery by the pancreas or progression to end-stage disease, provided there is ongoing inflammation or repeated episodes of pancreatitis known as the second hit. Now, this entire sequence of events is referred to as the SAPE hypothesis or the sentinel acute pancreatitis event. Now, in spite of this model, we know that 1/3 of patients may not have a prior episode of acute pancreatitis that before the diagnosis of chronic pancreatitis is made. However, this number varies based on whether it's a population study, such as the Danish cohort study, in which 2/3 of patients did not recall having a prior episode of acute pancreatitis, or in single center tertiary centers like ours, where studies show that less than 10% do not have a preceding episode of acute pancreatitis. Now, approximately 1/3 of patients who develop acute pancreatitis will eventually progress to chronic pancreatitis over 5 to 8 years. Also, it is important to know in the pathogenesis of chronic pancreatitis that the immune profile of chronic pancreatitis patients, recent studies show, is different and distinct from acute pancreatitis and controls with or without abdominal pain. In fact, there's a higher level of IL-17 and similar markers suggesting the role of T helper cells in the pathogenesis. Now, let's talk about individual risk factors in chronic pancreatitis. We all know that alcohol is a significant contributor. In fact, chronic alcohol consumption sensitizes acinar cells to injury by interfering with defense mechanisms in the pancreas. In fact, the risk of developing chronic pancreatitis is dependent on the amount as well as the duration of alcohol consumed. And this is very elegantly shown in a large study where individuals who were consuming more than 5 alcoholic beverages per day had a higher association of developing chronic pancreatitis, suggesting that there may be a minimal threshold that needs to be met. Now, in spite of all that, the risk of developing chronic pancreatitis from alcohol still remains quite low, less than 3%, even in such heavy drinkers. Now, recently, there's been attention on Claudin-2 gene mutations that are present on X chromosome. They have shown to have a higher rate of alcoholic pancreatitis, and their presence on the X chromosome also explains why men tend to have more alcoholic CP than women. Common sense tells us that alcohol cessation should be advised. It definitely improves pain, but it's not very clear if it improves endocrine or exocrine dysfunction. Now, several studies, including ours, shows that inpatient alcohol cessation counseling after the first episode of acute pancreatitis, followed by periodic interventions, does help in reducing the frequency of attacks in these patients, as well as 30-day readmissions. Excuse me. Now, smoking is as important as alcohol. In fact, there's an independent association of smoking with all forms of chronic pancreatitis, and up to 46% of all pancreatitis may be associated with smoking. In a large meta-analysis of 10 prospective studies, so pretty good data that showed a strong correlation with the number of cigarettes that an individual smoked and the duration, so in terms of pack years, and the association and development of chronic pancreatitis. The pooled risk estimate for developing chronic pancreatitis is 2.5 times higher for current smokers. And as one would expect, if an individual does drink heavily and also smokes, they're likely to be more detrimental effects on the pancreas. We do recommend smoking cessation. It definitely decreases pancreatic calcifications, which is a surrogate for severity, but there's no proof that it alters the natural history of chronic pancreatitis. But I would like to caution you that we know, and there's good evidence, that smoking does promote inflammation in the pancreas, and it clearly increases the risk of pancreatic cancer in chronic pancreatitis patients. Now let's move on to genetic risk factors and disease modifiers. These, with differing mechanisms and variable penetrance, are associated to a certain extent with chronic pancreatitis. Now, most chronic pancreatitis from genetic mutations is sporadic, which means that it doesn't occur in families, and usually you see the first case in clinical practice, and these typically occur before the age of 35 years. Now, the best studied genetic chronic pancreatitis is hereditary chronic pancreatitis, and as you know, it is a autosomal dominant disease with mutations in the cationic trypsin gene as well, or the PRSS1, with 40 to 90% penetrance and accounting for approximately 1% of all genetic cases. And in this disease, injury to the pancreas is from autodigestion from excessive levels of trypsin-1, either from premature conversion of trypsinogen or reduced inactivation. This is clinically manifested by symptoms before the age of 20 and rapid progression to end-stage disease, as well as a substantially increased risk of developing pancreatic cancer. Now, on the other hand, SPINK1 gene mutations are autosomal recessive. They by themselves do not cause chronic pancreatitis unless 2 mutations are present. They're typically disease modifiers and cause chronic pancreatitis in conjunction with chronic alcohol use or other gene mutations such as CFTR. And it does play a role in the development of tropical pancreatitis, which is seen in southern India. Now, moving on to cystic fibrosis gene mutations or cystic fibrosis transmembrane conductance regulator gene mutations. 5 different types have been described, where type 1 through 3 cause severe disease, and 4 and 5 have mild mutations. CFTR plays a role in secretion of bicarbonate by activating cyclic AMP in the ductal cells. This flushes out the pancreatic juice into the duodenum. And mutations can cause either recurrent acute pancreatitis or chronic pancreatitis, which are referred to as cystic fibrosis-related disorders. We are fortunate that CFTR modulators have been developed, such as ivacaftor, tezacaftor, elexacaftor, which have been used singly or in combination in some studies when there's defective CFTR or reduced CFTR. And what these modulators have shown is that they reduce the frequency of AP episodes as well as improve fecal elastase, which is an indirect marker of exocrine function. Now, lesser known disease modifiers such as chymotrypsin gene mutations, calcium sensing receptor, claudin 2, and carboxyl ester lipase are associated to a lesser extent with chronic pancreatitis. I wanted to clarify some terminology that we use in the world of pancreatology. The non-sporadic chronic pancreatitis that accounts for the remainder of 10% of genetic cases is either familial or hereditary. We've already spoken about hereditary chronic pancreatitis that occurs in the setting of pathogenic germline mutations of PRSS1. But familial chronic pancreatitis is a broader category of chronic pancreatitis that occurs at higher rates than the general population and occurs in clusters and families with 2 or more blood relatives involved across 2 generations, where the chronic pancreatitis has an unknown etiology and no known genetic mutations. So from a practical standpoint, when do we perform genetic testing? We should certainly consider genetic testing in individuals who develop chronic pancreatitis before the age of 35, and those patients that have relatives who have hereditary pancreatitis. It should also be considered if there's a family history of idiopathic chronic pancreatitis or childhood pancreatitis or recurrent acute pancreatitis of unclear etiology. What are the benefits of genetic testing? It does provide early information about the etiology. And even though immediate treatment is not planned, it does end exhaustive, invasive, and expensive testing. It is especially useful if radical therapies such as total pancreatectomy with islet cell transplantation is considered. And sometimes in patients, it just provides a meaningful resolution to poorly defined symptoms. Of course, we do not do testing when the disease is irreversible, as in end-stage CP. So now let's move on to the diagnosis of chronic pancreatitis. The diagnosis involves several criteria. You need the appropriate individual with the appropriate underlying risk factors, who then develops characteristic upper abdominal pain that is constant or intermittent, with or without amylase and lipase elevations, and then one supporting other criteria to make a diagnosis, such as presence of pancreatic calcifications or duct irregularities seen on CT, MRI, or ERCP. EUS criteria that are consistent or definitive for chronic pancreatitis. If we are using pancreatic function testing with secretin, then the peak bicarbonate in the duodenal fluid should be less than 80 milliequivalents per liter. We rarely perform biopsies for a diagnosis. So when these criteria are met, the diagnosis of chronic pancreatitis is straightforward in advanced cases. Now, the ACG did publish some guidelines, and they recommend, for obvious reasons, that CT and MRI be the first line of diagnosis, testing for the diagnosis of chronic pancreatitis. Now, if the CT and MRI are normal and the suspicion remains high, they do recommend endoscopic ultrasound as the second line of testing. endoscopic ultrasound findings can be scored either by the Rosemont criteria or Sahai criteria. The ACG does not recommend one scoring system over another, neither does it recommend the type or the number of criteria that we should use to make a diagnosis, as there's no high quality evidence supporting one system over another. EUS findings for chronic pancreatitis have an excellent specificity and sensitivity up to the order of 90%. But the biggest drawback of EUS and chronic pancreatitis, that it is invasive, it is completely operator dependent, and therefore prone to false positive results. Therefore, the ACG recommends that secretin MRCP or SMRCP be considered in patients who have normal CT, MRI, and EUS, and the suspicion for the diagnosis remains high. The way this MRCP works is that when secretin is given, it stimulates bicarbonate production via cyclic AMP in the ductal cells. This flushes out pancreatic juice into the main pancreatic duct and into the duodenum, allowing excellent visualization of the ductal system and filling of the duodenum. Hence, not surprisingly, these are the best studied features in chronic pancreatitis, in addition to T1 weighted scores, as well as arteriovenous ratios. The biggest benefit of SMRCP, as you would guess, is that there's no radiation. It can be used even when there is a contrast allergy. However, it does miss calcifications in the pancreas. Pancreatic function testing is excellent when available. It is only available at specialized centers. We typically use it to rule out chronic pancreatitis. We've shown 10 years ago that in long-term follow-up, if someone has a normal pancreatic function test, you have almost ruled out the future development of chronic pancreatitis in 97% of cases. Hence, it is an excellent rule-out test. We at our center do not use histology for the diagnosis, although ACG does recommend it. I think the recommendation is based more because of the EUS biopsies that have become safer. However, biopsies of the pancreas are not trivial, and they can still cause infection, fistulae, and pancreatitis. Moreover, chronic pancreatitis is a patchy disease, so if you biopsy the pancreas, you could have a sampling error, and you do require a pancreas pathologist to interpret the biopsy slides. Now, this slide shows some of the changes of advanced chronic pancreatitis. You can see calcifications on CT scan, resected specimen of the pancreas, as well as biopsy slides. We also see in the bottom left image advanced changes in the ductal system at ERCP with a markedly dilated main pancreatic duct and clubbed side branches. Now, this slide shows a normal MRCP on the left and chronic pancreatitis on the right. Let's focus on the right image, where there are subtle irregularities in the main pancreatic duct and less fluid in the duodenum in the bottom right image in the right frame, as compared to the normal image on the left. Now, this slide shows some of the Rosemont criteria, which include major and minor ductal or parenchymal features, with evidence of calcification at EUS, echogenic strands, dilated main pancreatic duct, and hyperechogenic ductal wall. So in summary, how do we make a diagnosis of chronic pancreatitis? It remains a clinical diagnosis with careful assessment of all the risk factors an individual presents with, the symptoms that they have, the results of the testing, and integrating all this evidence to make a firm diagnosis while we exclude other diseases. Now, when we diagnose chronic pancreatitis, we want to make sure we are not confusing it with autoimmune pancreatitis, which can at times resemble CP. However, it's distinct because the histology is different, as shown in this slide, in all three types of AIP. But the more important distinguishing feature is that AIP is exquisitely sensitive to steroids and causes reversal of pancreatic dysfunction, and as well as fibrosis, which is not seen in chronic pancreatitis. Chronic pancreatitis is not very common, less than 200 cases in the United States, but the true prevalence is somewhere around 70 cases per 100,000 adults. The incidence is approximately 10 cases per 100,000 adults. It is more common in men and more common in Black people. Now, over the next several slides, I want to discuss the clinical features and management of chronic pancreatitis. I want to focus on the main cardinal features such as abdominal pain, exocrine, and endocrine insufficiency. You should know and you must be aware that in the absence of disease-modifying treatments, the goal of treatment and managing chronic pancreatitis is based on symptom control and treating complications. Now, from a patient perspective, abdominal pain is the most relevant and consequential symptom of chronic pancreatitis, affecting up to 85% of patients. 10 to 20% are fortunate enough to have no symptoms and painless chronic pancreatitis. 3 different pain patterns have been described, and this is really important because the worst is type C, where the patient has constant pain all the time, 24/7. That is severe and unrelenting. We do see severe changes on CT scans, such as advanced calcifications, strictures, dilated ducts, as well as atrophy, but none of the severity of the morphological changes correlate with the intensity or type of pain in chronic pancreatitis. Now, you all know that the pain in chronic pancreatitis can be from a variety of reasons, such as obstruction of the main pancreatic duct from stones or strictures, from inflammation of the parenchyma, or compression from pseudocysts, symptomatic biliary strictures, gastric or duodenal outlet obstruction. But the most important and difficult cause of pain is neuropathic pain, where there's either inflammation of the nerves or functional changes that results in a state of heightened central sensitization, especially in type C pain patterns. And it is this remodeling of the nerves that explains why some patients have persistent pain even after a total pancreatectomy. Now, we did discuss how relevant constant pain is. It is an independent predictor of poor quality of life as well as other terrible outcomes in these patients. There's some genetic evidence that patients with anxiety and PTSD tend to have the worst pain genotypes. From a research standpoint, it is really important that we characterize and quantify pain so well thought out studies can be carried out, such as using sensory testing or pancreas-specific pain questionnaires. How do we manage chronic pancreatitis? The first step is to stop smoking and drinking. As mentioned earlier, it can improve pain. There's a lot of common sense in treatment. We do avoid long-term use of high-potency narcotics. We follow WHO principles of moving slowly with the analgesia, starting with NSAIDs first, and then over a period of time, progressing to low-potency narcotics such as tramadol with or without neuromodulators. Now, the ACG does recommend considering antioxidants early in the course of disease, largely because they are safe and not very expensive. However, the data is not very supportive of use of antioxidants with mixed results for pain management and quality of life issues. The typical antioxidants that we use are selenium, methionine, vitamin A, E, and C. There's one randomized controlled trial that combined antioxidants with pregabalin over a period of 8 weeks and showed that there was a reduction in pain intensity in the treatment arm compared to placebo and other outcomes. I want to emphasize that we do not recommend or use pancreatic enzymes and octreotide for management of pain in chronic pancreatitis. These are extremely expensive, and there are multiple studies as far as pancreatic enzymes are concerned that show no benefit, although it does improve abdominal bloating and cramping. An interesting small study came out of Dartmouth in 2015, where concomitant medical cannabis use decreased the opioid analgesia in CP patients along with recurrent admissions. We can also offer endoscopic and surgical treatments for patients with pain in chronic pancreatitis. The European Society does recommend specific criteria for endoscopy and shockwave lithotripsy in chronic pancreatitis. They recommend that this should be frontline treatment, specifically for patients who have painful chronic pancreatitis, where the head of the pancreas is affected and there's proximal obstruction with a dilated main pancreatic duct. And it appears that patients who have short disease duration, who are not using opioids, who don't have strictures, tend to do better. They also make recommendations on how to clear the stones from the main pancreatic duct based on radiolucency of the stones. Large, greater than 5 millimeter radiopaque stones should be tackled first with shockwave lithotripsy or ESWL. And if those centers, if centers don't have ESWL, you can refer them to a specialized center for ERCP with pancreatoscopy and intraductal lithotripsy. In cases of radiolucent stones or small stones, one can directly proceed with ERCP without pancreatoscopy and stone extraction. Now, we don't routinely perform ERCP once shockwave lithotripsy is done, but we wait for spontaneous clearance of the ducts. If stones still persist in spite of adequate fat fragmentation, then ERCP can be used for stone extraction. If a patient has painful main pancreatic duct strictures, the principle is to start with a single plastic stent of the largest diameter possible that can be safely deployed. It should be left in place for at least a year and changed every 6 months, or if there's dysfunction, it should be changed earlier. If at the end of 1 year, there's persistent or refractory strictures that are still painful, you can put multiple plastic stents or refer them to surgery. We don't recommend putting fully covered metal stents in the pancreatic duct. We already spoke about symptomatic pseudocysts. Endoscopic treatment is preferred over IR or surgical treatment. Similarly, for biliary strictures, where we can either use multiple plastic stents or a single large fully covered metal stent, which are equally efficacious. Now, what about celiac plexus blocks in chronic pancreatitis? I think this is very controversial. There is no data to support the use routinely, largely because these are single-arm studies that did not compare with either placebo, sham, or medical treatment. But in spite of that, ACG does recommend that it could be tried in selected patients. In my mind, these selected patients would likely be those that are heavily opioid dependent or have significant adverse effects to opioids or have diffuse pancreatic disease that is not amenable to endoscopic treatment or surgical resection. If celiac plexus block is considered, it should be EUS guided, in my opinion, as it is more efficacious than fluoroscopic or CT guided celiac plexus blocks. And typically we use a local anesthetic with steroids. The ESCAPE trial was an excellent trial carried out by the Dutch group at multiple centers in the Netherlands and published in JAMA in 2020. They had 44 patients in each arm of early surgery or endoscopic therapy. They carefully selected patients who had painful, uncomplicated chronic pancreatitis with a dilated and obstructed main pancreatic duct. And what they showed was early surgery reduced pain, were more likely to produce complete and partial pain relief and with less number of interventions. However, surgery did not impact other important outcomes such as quality of life, complications, mortality, etc. Also, surgery was more cost-effective in terms of reducing pain score as well as gain in quality-adjusted lives. Now, in spite of the fact that surgery is superior to endoscopic therapy for specific types of painful chronic pancreatitis, surgery is rarely performed upfront. This is largely because of patient preference and also because of surgeons who prefer to wait until endoscopic treatment fails. The surgeons have put some consensus guidelines together, specifically focusing on what kind of surgery should be performed based on the anatomy of the pancreas. They strongly agree that surgery should be done early if there are local complications and there's risk of missing pancreatic cancer. But based on anatomy, for groove pancreatitis, a Whipple procedure is recommended. If the head of the pancreas is enlarged, a combined resection and drainage procedures such as a fray or a burn procedure. If the head of the pancreas is normal, then either a resection procedure or a drainage procedure, such as a lateral pancreatic or jejunostomy, can be done. And in cases of hereditary pancreatitis, we recommend a total pancreatectomy with or without islet transplantation, which is also known as TPIAT. Now, TPIAT is infrequently performed. It is only performed at specialized centers. Once again, it is performed only for patients with intractable pain and those who have failed medical, endoscopic, or surgical therapy and have poor quality of life. TPIT is extremely useful in patients with hereditary pancreatitis as it removes the risk of secondary pancreatic cancer, and it should be done early so as to preserve islet functions so that the patients don't develop diabetes from fibrosis of the islets that need to be perfused into the liver. It can sometimes be performed in diffuse small duct pancreatitis that is not amenable to surgical resection or drainage procedures. And as with all surgical procedures, it is best carried out when patients are not opioid dependent, don't drink or smoke, and if it's early in the course of disease. So what are the specific benefits of TPIT? Knowledge comes from large follow-up studies from Minnesota, where they show up to 90% pain relief at 15 years follow-up, with more than half the patients having partial or complete insulin independence, and significant reduction in narcotics and improved quality of life. However, the big problem remains that a fraction of patients may still have pain after a total pancreatectomy, and this is going back to the presence of neural remodeling and central sensitization that causes pain in these patients. I want to point out that non-structural interventions are very helpful and support patients with painful chronic pancreatitis. If available, they should be offered behavioral and cognitive therapy, addiction counseling, social work support, physical therapy, resilience training, etc. We do not routinely recommend acupuncture for management of pain or spinal cord stimulation, as now there are several studies that show that they're not very effective. Now let's move on to the second cardinal symptom of chronic pancreatitis, which is exocrine insufficiency. It invariably affects all patients at some stage of their disease, and is because there's less production of enzymes, and it requires 90% of the gland to be destroyed before insufficiency sets in. As you all know, the clinical symptoms are steatorrhea, weight loss, bone disease, malnourishment, vitamin deficiencies, etc. And as the disease progresses, the insufficiency becomes worse, especially if they've had surgical resections, and especially if they continue to drink and smoke. Diagnosis of insufficiency is made by fecal elastase testing. Levels between 50 to 100 micrograms per gram are diagnostic, with less than 50 being very specific for chronic pancreatitis. You can see false positives if you have a diluted stool sample, and also levels greater than 100 can be seen in IBS, IBD, diabetes, chronic renal disease, etc. Now, even though it is the gold standard, we rarely perform quantitative fecal fat testing, which involves collection of stool samples over 2 days, as well as a challenge of 100 grams of fat per day. As I mentioned, bone disease is very common, affects almost 2/3 of patients. Osteopenia is more common than osteoporosis, and the risk of osteoporosis is 3 times that of the general population. Most of these patients are unfortunately prone to spontaneous fractures and low trauma fractures, which is sometimes worsened if there are cofactors like associated vitamin D deficiency, hypogonadism, and ongoing alcohol and tobacco abuse. So how do we treat insufficiency? Of course, we do recommend patients stop drinking and smoking, but the mainstay of treatment is pancreatic enzyme replacement therapy, which should be done and is effective in appropriate and high doses, and to be given with food and in the setting of acid suppression using PPIs, because lipase in these enzyme preparations can be inactivated at pH less than 4. To understand the dosing, it is important to understand the normal physiology of the pancreas. The normal pancreas produces 90,000 United States pharmacopoeia units of lipase with each meal. So in general, what we recommend is half that dose for major meals and half of that for snacks. So 40 to 50,000 units of lipase with lunch, breakfast, and dinner, and 20,000 units of lipase with snacks. We typically recommend splitting the dose with the first dose taken with the first bite and the second dose 10 to 15 minutes into the meal. And now, in spite of that, patients will still have malabsorption, and there are several reasons for that. We should ensure that patients have been compliant and are dosing their enzymes appropriately with meals, and they are taking PPIs, etc. Sometimes enzymes can be given at the end of the meal if the dose is not sufficient. But if they continue to have malabsorption, then we should strongly consider other GI conditions, especially SIBO, which is highly prevalent in chronic pancreatitis and up to 40% in patients who have pancreatic resection. Patients who tend to get in trouble with SIBO are those that are opioid dependent, who are diabetic, and those who have more severe disease with low zinc levels. It is very important to know that we do not recommend a low-fat diet for our chronic pancreatitis patients. In fact, we recommend a cardiac healthy fat diet, as low-fat diet has been shown in several studies to exacerbate weight loss as well as fat-soluble vitamin deficiencies. Now let's move on to the third cardinal symptom, which is diabetes. There's a specific type of diabetes seen in chronic pancreatitis, also known as pancreaticogenic or type 3C diabetes, which substantially increases the risk of pancreatic adenocarcinoma. You diagnose type 3C the same way as you do type 1 and type 2. In fact, type 1 may still be present in 3% of CP patients before their diagnosis, and type 2 may exist in 40% of patients before their CP diagnosis is made. Approximately 1/3 of patients, when they're diagnosed with chronic pancreatitis, will develop new onset diabetes within 1 to 2 years of their diagnosis, and 50% or more patients will eventually have diabetes. The diabetes and chronic pancreatitis is because of a different mechanism. It is because of inflammation and fibrosis and destruction of all the islet cells. As a result of that, alpha and delta cells are also lost, and there are low levels of glucagon and pancreatic polypeptide, and this makes patients prone to hypoglycemia. The majority of patients will end up on insulin, although early we can treat with metformin. Who develops diabetes in chronic pancreatitis? It is usually men. It is those patients that have evidence of disease progression by surrogate markers such as calcifications, steatorrhea, or biliary strictures, and those who have modifiable risk factors such as ongoing alcohol and smoking, and those who've had a distal pancreatectomy, as most of the islets are in the tail of the pancreas. Now let's move on to complications. Most of the complications are anatomical, in addition to the nutritional ones that we discussed earlier. Splanchnic venous thrombosis affects 1 out of 5 patients. Involves splenic nerve most commonly, and less often portal vein and superior mesenteric vein. Splenic vein thrombosis can rarely cause gastric varices, but these typically do not bleed, and we tend not to anticoagulate our patients. We've already spoken about pseudocysts that are symptomatic, outlet obstruction, as well as symptomatic biliary strictures. We do recommend endoscopic treatment over surgical or IR treatment first. Pancreatic cancer is a serious problem in chronic pancreatitis. The risk is up to 5% in older studies, but we published a study 2 years ago that shows that the risk is substantially lower in a population of 1 million VA patients. It's to the order of 1% compared to 0.2% for controls. And this risk goes above 1% if CP patients smoke and drink, or have new onset diabetes. We've already discussed the high risk in hereditary chronic pancreatitis of up to 10%. Unfortunately, the lifespan of CP patients is 10 years shorter than the general population. The risk of death is almost 5 times higher, as shown in the Danish population and cohort study. The cause of death is typically cardiac and GI first, and then cancer, either pancreatic or non-pancreatic. Frail pancreatic patients do worse than low frailty index patients, with increase in patient mortality, longer lengths of stay, and more renal failure. I wanted to talk about two aspects of chronic pancreatitis that are important in their management. Quality of life is a big issue for CP patients, as you would expect. It is terrible. It is worse in patients who have type C pain. It's worse in smokers who also tend to have psychiatric illness. It is obviously worse if you have other medical problems. We have shown that 70% of patients with chronic pancreatitis have sleep disturbances, which directly affects their quality of life. We have also shown a higher rates of sexual dysfunction in men who have chronic pancreatitis, but surprisingly, sexual dysfunction did not affect quality of life in these patients. An interesting piece of trivia is that CP patients have the highest rates of leaving the hospital against medical advice compared to other medical diagnoses, 3.9% versus 1 to 2%, excuse me, for other medical conditions. Opioid use in chronic pancreatitis is a big problem. Those who use opioids versus those who don't have poor outcomes. We published our data last year, and we've shown that patients who use opioids have numerous poor outcomes, including more GI symptoms, more enzyme use, more resource utilization, such as more ER visits, more scans, more endoscopic interventions, more surgery, etc. These patients also tend to use more medical marijuana, sedatives, and neuromodulators. However, the silver lining is that after the implementation of the statewide prescription monitoring program, patients, at least in Massachusetts and New England, 87% of these patients we have shown get all their prescriptions from a single facility, opposed to the remaining 13 that get it from multiple facilities, typically from their ER visits. This will hopefully minimize opioid use and misuse in CP patients. Now, I want to wrap up with the recommendations on how to follow these patients when we see them in the office once their diagnosis is made. This comes from guidelines we published in 2017 from the Consortium of Academic Pancreas Centers of Excellence. Pancreas patients should be seen annually and more often if they have concerning symptoms. We recommend smoking and alcohol cessation, which is common sense. We also like to focus on the character and change in character of pain, because that is important, along with weight loss, diabetes, jaundice, unexplained thrombosis, as all these could be a sign of developing pancreatic cancer. Patients should get annual labs and malabsorption markers. We should record their weight, their BMI, and if available, assess them for evidence of sarcopenia. We've already discussed screening them for bone disease with baseline bone densities. Their vitamin D levels should be checked. They should be assessed for fracture risks. We screen them annually for diabetes with hemoglobin A1C, evaluate them annually for malabsorption, and give them appropriate enzyme doses. We definitely should not do annual CT scans or MRIs in these patients, especially to screen for pancreatic cancer in non-hereditary chronic pancreatitis. And then we should use some common sense global measures, such as addressing their medical problems, making sure that they have been addressed by their PCP, quality of life concerns, as well as offering non-structural interventions that we spoke about earlier. Now, I want to end with this slide. Our biggest concerns in the management of chronic pancreatitis remain twofold. One is understanding and managing pain. We still don't understand this aspect of chronic pancreatitis well at all. Also, we do not know how to prevent progression of disease. The hope is that this could be best addressed by our ability to diagnose chronic pancreatitis early in the course, perhaps with biomarkers, as shown in a promising paper in Gut in 2021, and perhaps halt the progression of disease by patient-focused drug development, such as gene therapy or CFTR modulators. I wanted to talk a little bit about the Goulash study, which may help in this endeavor. It is a multi-center European study that started in 2019 when they recruited well-characterized patients with the first episode of acute pancreatitis, and they've been following them with the plan to assess them annually and at the end of 7 years. So we should have results in a couple of years now. These patients have their blood, urine, and plasma samples collected for biomarkers. And the plan is to see who develops chronic pancreatitis and what are their biomarker profile. The TACTIC trial is something I want to conclude with. This was a negative trial in the United States, just concluded in March of 2000, published in March of 2024 in CGH. This was a multi-center US trial using camostat mesylate as an analgesic agent. This was prompted by the success of this agent in Japan. However, in the US, different doses of camostat compared to placebo were not effective in pain control and had 16% adverse effects. So with that, I'll conclude this talk. Sorry I had to speak a little fast to get through a lot of information, but I look forward to answering questions during our panel discussion. Thank you so much.